my name is Roberto Mina. I'm a hematologist at the University of Turin, Italy. And we have presented at the EHA 2021 meeting the results of a subgroup analysis of the FORTE study in patients with complete cytogenetic data to evaluate the efficacy of 3 different induction, intensification, and consolidation therapies, including carfilzomib, lenalidomide, and dexamethasone, or carfilzomib, cyclophosphamide, dexamethasone with or without transplant as upfront treatment for newly diagnosed multiple myeloma patients, followed by a second randomization with carfilzomib, lenalidomide, or lenalidomide alone. And we were focusing on the efficacy of this induction, consolidation, and maintenance strategies to evaluate whether KRd plus transplant or KRd continuous or CCyd transplant, as well as KR maintenance or lenalidomide maintenance alone, were able to somehow overcome the poor prognosis that is carried by the presence of high-risk cytogenetic abnormalities in patients with multiple myeloma. All patients were transplant eligible and aged 65 years or less. And what we have observed is that the best outcome in high-risk patients, meaning those patients with at least one cytogenetic abnormality, or patients with double-hit multiple myeloma, which is patients with at least 2 or more high-risk cytogenetic abnormalities, was observed in patients that were randomized and treated in the context of KRd induction, 4 cycles, transplant, KRd consolidation, as well as in patients receiving carfilzomib lenalidomide maintenance, again, against lenalidomide maintenance alone. The progression-free survival of high-risk and double-hit multiple myeloma patients was significantly longer in patients treated in the KRd HSCT arm as compared to continuous KRd without transplant, and as well as compared to patients receiving CCyd plus transplant. And this was true also for double-hit multiple myeloma patients. The outcome of high-risk patients and double-hit patients was not as good as the one in standard-risk patients, so we cannot say that KRd transplant completely abrogated the poor prognosis of high-risk patients, with high-risk cytogenetic abnormalities. And this was also true for the maintenance strategy. The progression-free survival with KR versus R maintenance was prolonged in standard risk, high risk, and double-hit patients, with the best 3-year progression-free survival from start of maintenance observed in patients with standard risk disease, as compared to those in high risk and double-hit myeloma, whose 3-year progression-free survival from start of maintenance was 67 and 62% in the 2 groups respectively. Still, KRd transplant and KR maintenance provide an effective induction, intensification, and consolidation strategy, as well as a maintenance strategy for high-risk patients with multiple myeloma, particularly in light of the lack of other effective strategies and lack of randomized data in this setting.